Before we start the session, so personality disorders and eating disorders, some of this stuff might come, I guess with any of the psych stuff, might hit kind of close to home. So if anyone afterwards wants to message me on Facebook or something, if, I don't know, something was particularly sensitive or whatever, I'm perfectly happy for you to do that. But just to say, because, yeah, they are really, really quite common and really distressing. We'll start with personality disorders. This session is going to include a lot of me, not philosophizing, but I have, especially with personality disorders, some views on them as psych diagnoses. So let's start with that, and with that most horrific of questions. Anyone want to say what a personality disorder is? And you can probably type basically anything and you'll be right. That's part of the problem with the diagnosis of personality disorder. Actually, come to think of it, that might take a while. So to save everyone time. Oh no, someone has said it. Perception of social standing and structure not keeping with the norm. Yeah, that's definitely a part of it. Try and think what your definition of a person's personality is, and see how much you struggle with it. It's sort of like the idea of, you know, saying that something is pear-shaped. It's this, it's the shape of a pear. Now tell me what the shape of a pear is. It's really, really difficult. It's just something that's so ingrained that, oh, people have personalities, but what the hell actually is a personality? You've got your formal definition from the ICD-10, which is a severe disturbance in the characterological and behavioral tendencies of the individual, usually associated with a considerable personal or social disruption. And as you can see, that's really broad, encompasses a lot of things, and to be honest, is not the most helpful thing as compared to, let's say, the definition of something like schizophrenia, especially within psychiatry, where all of your diagnosis is done on fairly arbitrary classifications and diagnostic criteria. The important thing is all of us have personalities, and our personalities are made up of traits. But what makes something a disorder? That's really what is the important question here when you're trying to say, is somebody having a personality disorder? If I asked you to say, what is a disorder? Someone want to give that a shot. What's the definition of a disorder? We talk about it every day in medicine, illness, disorder, disease, but what actually is a disorder? It's again one of those questions where it's something that you talk about so often that's practically tacit knowledge. But then when somebody turns around and says, so what is a disorder? You're sort of there like, what? Yeah, so what Olivia said, which is something that causes a functional impairment to the patient. That's the key bit. Your function is impaired. So if I was a person who was quite shy, that's just a thing. I'm quite shy. If it had gotten to the point where I'm so anxious of dealing with people, I do not go outside and I can't get a job, and because of that I can't get an income, I can't rent a place, and I can't move out of my parents' home, that's a disorder. There's a big difference. It comes in with depression, for example, how there's a difference between being sad and being depressed, because one of them is a feeling that can be fleeting, the other one is this could kill you. So what Olivia says, so it's the functional impairment that's the really, really important bit. So if we talk about diagnostic criteria, personality disorders have each one has some of their own ones, but there are criteria like default personality disorder criteria, which you need to fulfill to get a diagnosis of any personality disorder. What is the first criteria of any psychiatric condition? Vague question, but in order for someone to be diagnosed with a psychiatric condition, what is criteria number one? remember that all psychiatric diagnoses are technically diagnoses of exclusion. So what does that tell you? Perfect. So what Annie said, that you cannot attribute it to an organic cause. Can't be brain damage, can't be a neurological disease or an endocrine dysfunction. It has to be due to something once all of those have been ruled out. So if we have a look at the diagnostic criteria, and let me clarify, for your SBAs, you will need to know very little of this, and I'll point out the bits where this will come up as an SBA, this will come up as an SBA. This bit's just something that's actually quite useful once you're working as a doctor and seeing patients with these conditions. And in terms of the OSCE, if they gave you a station on eating disorder or a personality disorder, that's a bit of a dick move. Because as medical students, we're not taught much about them. The stuff that I'm going to be telling you is probably going to be more than most people will get in teaching during their psych work. So we said symptoms can't be attributable to an organic cause. There are disharmonious attitudes and behaviors. You'll see throughout this presentation there are lots of things that either I've put inside inverted commas, or which sound like they should be, because they're very arbitrary, and the sort of thing where a group of people came together, wrote them down, and it's very generalizable and sometimes quite unfair and even stigmatizing, which is why I'm not the biggest fan of personality disorders as a diagnosis. But yeah, so disharmonious attitudes and behaviors that involve several areas of function, like Olivia said. And the thing is, it's long-standing, it's not episodic. So personality disorders don't come and go like something like schizophrenia, which is relapsing, remitting. They're just there. One of the important bits, and this is something that can come up in an SBA, is that obviously personality is something that develops. You don't wake up one day and your personality is solid. And because personality develops, you can't actually diagnose somebody with a personality disorder until they're 18. You can say, well, this person's almost certainly going to get a personality disorder. And there's a thing in child and adolescent mental health, which is very common, the idea of emotional dysregulation. And you'll see a lot of that if you ever work on a CAMS ward. A lot of the patients will have emotional dysregulation down as their diagnosis. The moment they turn 18, that's probably going to be changed to emotionally unstable personality disorder. But you cannot technically diagnose somebody with a personality disorder until they're 18, because the idea that it hasn't solidified. It's maladaptive, obviously, and it will continue into adulthood, and it's distressing. The patient may not notice it until way later on, and it may be the whole problem may be brought up by other people, but it is distressing and will lead to an impairment in quality of life. These things aren't uncommon. If you work in psychiatry, a lot of your patients will have a personality disorder, and it's much higher in certain populations, especially people who are quite vulnerable or neglected, so lower socioeconomic classes, the homeless, the incarcerated, children who have had an unstable background, so have had to go into foster care or things like that. And obviously, if you ask someone why do they happen, you will get the whole, well, it's complicated and multifactorial, and there's biological and social and psychological factors, but really, really a lot of it is social. Personality disorders and eating disorders are two of the most social, well, psychosocial groups of psychiatric disorders there are. On the opposite end of the spectrum, something like schizophrenia or bipolar, which is much, much more biological and genetic. And I have never seen a patient with emotionally unstable personality disorder who didn't have a somewhat traumatic childhood. So including things like an unstable home, being abused sexually, physically. These are all huge risk factors for developing a personality disorder. Sometimes it doesn't have to be as severe as that. Sometimes it could be you were a child in a household of 7 and you didn't actually get the attention that a child needs to sort of develop healthily. But other times it can be all the way to someone's had a horrific childhood. They're divided, again, arbitrarily into these 3 clusters, and we'll talk about that a bit. Fortunately, ICD-11 is revamping the whole personality disorder thing so that it's no longer 10 arbitrary diagnoses, but a diagnosis of personality disorder, mild, moderate, severe, with certain qualifiers like borderline, personality disorder with borderline traits or with negative affective traits, and so on. So let's move on to our first cluster. So anyone know what the first cluster of personality disorders is? We're in SBA land here. An important thing with the clusters, they all have one word associated with them, and they're all stupidly stigmatizing. There we go. So cluster A is the odd or mad disorders. I honestly hate this whole thing so much. You can see how stigmatizing this all is. These are 3 arbitrary conditions. Anyone know what the 3 personality disorders that come under here are? The fact that you can stereotype these and it's basically a box that you can put patients in is honestly one of the most frustrating things in all of medicine. Imagine you're given a diagnosis which has the word mad or odd associated with it. That is peak stigma. So, what 3 come under cluster A? Schizoid, perfect. And the other 2? Schizoid, schizotypal, and the one last one, paranoid, perfect. We'll quickly talk over these because basically it might be an SBA, otherwise you will never hear about these. They very rarely get diagnosed because often they don't actually present to services, and either they'll get diagnosed because somebody has been picked up for another reason and seen by the mental health team, like in hospital where you think they're depressed, they've come in as a NOF or something, and actually no, they have a schizoid personality, which essentially is just someone who doesn't really want to interact with people. But it's gotten to the point where the functioning is impaired because they don't seek help when they're unwell or something like that. So symptoms for schizoid is they like being on their own. They are emotionally not really there, so flat, detached with other people. They're not very interested in interpersonal relationships. They might have a friend or 2, but otherwise they don't really. And it doesn't really bother them. The problem with it is the fact that it will eventually lead to some form of disruption to quality of life, where it might be harder to keep a job because you know people don't like having you as a colleague because you're so distant or so on. But this is probably the one which is the most, why is this a personality disorder? Why is this a disorder at all? It's just people who like being on their own. That's the SBA land bit. Guy's brought in by his parents. He likes being on his own, likes spending time playing computer games, has a job, doesn't really like hanging out with other people. What personality disorder is this? It's linked to a pure. So the tidbits, which are the more like this is more out of interest or future relevance, you're not likely to see them because they don't self-present. They do, a lot of them have suicidal feelings, but they don't often go through with it. So it's one where there's a lot of suicidal ideation, but the suicide rate's fortunately quite low. Schizotypal is the classic, the stereotype of schizotypal is the bizarre person who dresses really colorfully and has magical thinking. The important thing about this one is this is the only one, despite the other one being called schizoid, this is the only one which has a genetic link to schizophrenia. So if you've got a history of schizophrenia, risk of schizotypal personality disorder is higher, and B can actually progress to schizophrenia. And that is basically the only important bit about it for us at the moment. It's just people who are eccentric, but to a degree where it can be quite disruptive. Paranoid is the one which makes the most sense as a disorder. And as the name suggests, these people can have almost delusions of persecution, but they're not entirely. They're what's called a overheld thought, which is a delusion, but not quite there, and that you can still kind of sway the person, and they'd be like, yeah, well, maybe I'm wrong. But these are the people who are prone to misinterpreting anything another person does as being something hostile or yeah, they can bear grudges for a very, very long period of time. I hate this cluster so much because you can look at the word associated with it, but essentially this is SBA land stuff. You won't often see these patients in your practice. We'll move on to cluster B. I won't put the slide on just now. Cluster B is it has two of the most common, and in fact cluster B has probably the most important personality disorder and the one that you'll see most often. Which one am I talking about? What is almost the personality disorder? Yeah, emotionally unstable personality disorder. This is a horrible disorder. Imagine a condition where, because of a disrupted childhood, you have grown up to be a person who is terrified of abandonment and terrified of letting someone in too close because they might abandon you, but at the same time wanting someone to be there for you. And then because you were never really taught how to interact properly with people or never really learned how to do it because of your disrupted childhood, you resort to things which other people see as immature or straight up not okay, like threatening, manipulating behavior, so common things like threatening self-harm or attempted suicide if you don't get the thing that you want, which is unfortunately why it's probably one of the most stigmatized mental health conditions and the most within the healthcare sector. I don't know how many of you have seen doctors going, shit, I don't want to see that patient. They've got EUPD, or have encountered patients with EUPD and found that they are very, very difficult. It's really, really hard because obviously there's oral symptoms of their disorder, but it's very difficult not to take it personally as this person hates me or this person is trying to manipulate me, rather than this person doesn't know how to do things the normal social way. What sort of things characterize emotionally unstable personality disorder, apart from the sort of namesake of the fact that they've got insane emotional lability? What the average person thinks bipolar is, which is the up, down, up, down, up, down over minutes and hours, is what EUPD is. What other things are very common in EUPD? So it's quite a list of them, list of sort of common symptoms. Yeah, what's that called, Lizzie? So Lizzie said they either love or hate people around them. And there's a name for that term, which is almost exclusive to EUPD. That's all right. So it's oh, let's see if someone said it. Yeah, perfect. Annie said it. So it's called splitting. Splitting's very, you can almost say it's quite specific for EUPD in that it's very much black and white thinking. So imagine if I had a friend and I was having a bad time and I messaged them and they replied to me and they were supportive, and I'm thinking, oh my God, I love this person so much. They're the best person in the world. And then the next day I woke up and I messaged them good morning and they didn't reply within a couple of minutes. And immediately I'm thinking, they hate me. I hate them. They are the worst person in the world. That's splitting. It's really distressing. It's distressing for friends and relatives as well, because out of nowhere, suddenly you're being told, why did you do that? What have I done? Why would you do this to me? And you can see it's really, really disruptive. Other things are your sort of feelings of emptiness, this intense fear of abandonment, which often stems from a disrupted childhood, and self-harm and attempted suicide are really, really common. I hate the phrase cry for help, but often that's the best way to describe the suicide attempts. A lot of the time, they're not, they can be taken not with the intention of actually ending life, but getting someone to say, look, I'm really unwell, help. The thing is that often then leads to people going sort of boy who cried wolf sort of thing, where, oh, they're not actually going to do it, but EUPD does have a 10% suicide rate. So 1 in 10 of these people will actually take their own lives. So it's this really difficult thing when it comes to risk assessment, which is, they've got EUPD, and this is something they've attempted suicide 3 times this year. They've done it again now. Is this going to be just like the last few times, or is this one way more serious? And if I send them home, they might actually try again more seriously. So the SBA stem is usually a person with lots of self-harm scars, repeated suicide attempts, can't maintain relationships, and it'll say something like, what's the most appropriate treatment? And what would the answer to that be? EUPD is a condition that's interesting because it had a therapy specifically designed just to treat it. Anyone know what that is? Dialectic behavioral therapy, and we'll talk about that in a second. So EUPD is by far the most important personality disorder for us to know about because you'll see it a lot in practice. There's some crazy statistics with it. I think something like over 10% of people in prison have it. And once you go on to inpatient mental health units, it can go up to at least a third of patients having it, especially if you go onto a female ward, because women are more commonly diagnosed with it. What else was there to say about it? There's a lot of comorbidity. And what did we also say? Yeah, remember, please, that their behaviors are a symptom of their condition because they don't know any better. Antisocial is the closest thing we have to psychopathy as a diagnosis. It's way more common in men, so it's one of the more commonly diagnosed ones, and these are the people who you essentially would call psychopaths. No empathy, callous, no regard for others, are more likely to blame others than themselves for things which they've obviously done, and very prone to aggression and violence. A lot of criminal offenders will meet the criteria for a diagnosis of antisocial personality disorder. That's a really good question, Olivia. That's a really, really good question. I think it's almost certainly that it's overdiagnosed in women. Here's an interesting thing. A lot of the neurodevelopmental conditions in women are misdiagnosed as things like EUPD or bipolar. A lot of women with autism spectrum disorders do not get diagnosed with autism until they are in their 30s and will have been misdiagnosed often as EUPD or bipolar and have been on several medications until someone eventually goes, wait, you might be autistic, and then you go down that route, which is obviously really sucky because a boy might get diagnosed when they're 5 or even earlier and get support for that, but women tend to be misdiagnosed with sort of this idea that, oh, it's you being emotionally unstable rather than actually there's a neurodevelopmental condition. ADHD is another good example. Women with ADHD, girls with ADHD often don't get diagnosed with it, and as they get older, it's untreated and they'll be misdiagnosed with something like EUPD. Men can get underdiagnosed with EUPD because they're not as expressive in terms of their emotions, and their sort of impulsive acts may be interpreted as due to something else rather than EUPD, but that's a really, really good question. And I would say a lot of it is overdiagnosis in women with neurodevelopmental disorders being missed, which is a real tragedy because imagine you go 20 years or so not getting the support you need with something like ADHD or an autism spectrum disorder, and instead you've been on lithium and quetiapine and olanzapine and all the side effects from those, and wondering why you're not really getting better. So that's a really, really good question, because theoretically, because there seems to be some biological role, but because a lot of it is social, you'd think there shouldn't be that big a gender gap. But there is quite a big gender gap, and I do think a lot of it is women being misdiagnosed with it. EUPD is a very catch-all diagnosis, which is sometimes you might see patients who they don't fit neatly into depression or something, or anxiety disorder or whatever, and they'll be diagnosed with EUPD. In fact, the American term for it, borderline, it's about 100 years old, but the whole stem for it is these are a group of patients who weren't psychotic, so didn't fit schizophrenia, weren't neurotic, so didn't fit the neurotic disorders back in the day, but were on the border of both, which is why it's called borderline personality disorder. So it's a bit of a, I hate to say, sometimes throwaway. Sorry, I've gone on a bit of a tangent, but that's a really good question. So if you see someone who is not getting better, especially if it's a woman, consider that they've been misdiagnosed and something more neurodevelopmental has been missed. So antisocial is the classic, what people think a psychopath is. Remember, psychopathy is not an actual diagnosis, but this is the closest it gets to it. Narcissistic, again, the distress from this comes from people not acknowledging how amazing you are and being jealous that other people are getting the attention that you think you should deserve. As a result, they're quite prone to really bad depression. And again, they won't usually present with that. They'll present with depression, and then you might untangle elements of narcissism. And then histrionics, an awful one. Histrionic is essentially the idea that, wow, this person's really attention seeking, wants to be the center of attention. As you can see, part of the, literally, this is a criterion, inappropriate seductiveness in appearance and behavior, which is, I'm not really going to say anything about that, but histrionics, if it's gotten to the point where it's distressing somebody, that's the diagnosis they get. But I do certainly think that was a diagnosis that people kind of sat around a table and came up with no real concern for, well, what does this actually mean for patients? What can we do for them? It seems very academic, but oh well. Finally, cluster C. Cluster C is seen as the anxious patients. I just quickly want to ask a question, because obsessive compulsive personality disorder is in this cluster, and this is a point of confusion sometimes. If you had to explain the difference between OCD and OCPD, so the personality disorder, what would you say is the difference? Perfect. So Annie has said OCD patients don't like doing the behaviors but feel compelled to, whereas OCPD patients don't mind doing them. So, just quickly with cluster B, so the important bit, EUPD is the important one. The rest don't really matter other than be able to recognize them in an SBA thing. EUPD is the really important one to know about because you're going to see EUPD patients whatever you do. Psych, ED, GP, you'll see them on medical wards, surgical wards. Okay. C, so the anxious. Avoidant can be summarized as sort of the example I gave earlier on, which is anxious to the point where this is a really controversial one because some people go, what's the point of this diagnosis? Surely it can fit under anxiety disorders as well. I've never seen somebody diagnosed with it. The idea is they're very comorbid with anxiety disorders, but I still don't really get the difference particularly, but that's sort of the summary of what they are. People who have very low self-esteem and are scared of interacting with others lest they be rejected or ridiculed, despite that it's not like with schizoid personality disorder where you want nothing to do with other people, you're just not interested. These people want to interact with others. They have a desire for intimacy and connection, but they are just afraid of being rejected. And the thing with them is that it can get quite dangerous in terms of self-harm, because if they have that and PTSD, which is actually interestingly quite often comorbid with it, their self-harm rates exceed EUPD, and EUPD has a very high self-harm rate. EUPD is the one where if you see somebody whose arms are often covered with self-harm scars, you think they've got EUPD, but avoidant can get worse than that, which is quite stark, really. Dependent is the one where a patient is essentially happy for somebody else to control their life, and when that person isn't there, they fall apart. This is an interesting one, which is it usually surfaces once the person's well, the person they were dependent on passes away or leaves them or goes away for an extended period of time, and then everything falls apart. They aren't used to making decisions for themselves and so on. Again, haven't really seen it, but this one is one of the ones that makes a bit more sense as to why it exists. OCPD, so Annie said that they don't mind doing them. So the way I always remember is OCD, you are very much distressed. You know that there is something wrong. OCPD, the distress comes from the fact that other people aren't doing things the way that you do it, and why is everybody essentially incompetent or so on. And it's almost the exact opposite in some ways to avoidant, not avoidant, antisocial, that you are very cautious, preoccupied with rules and regulations and being organized. Everything has to be done perfectly. And it gets to a point where it interferes with task completion. So some people lose their jobs because they aren't doing things quickly enough, because they're so occupied with getting it right that they forget about timing criteria and so on. The interesting thing about that one is it's a classical medical student syndrome thing. A lot of people will read about it and go, oh my God, do I have this? Here's an important thing with personality disorders. Personality disorder is when it's the full-on disorder, but remember, personalities are made of traits, and lots of people have personality disorder traits. Most medics are going to have obsessive compulsive personality traits. It doesn't mean you have a disorder if you're still able to function, essentially. That's why personality disorders are a bit weird. So that's cluster C. Quickly about management: therapy. You'll often see these patients on a lot of medications. Between you and me, that's basically trying to deal with symptoms, which is what medication does to a degree, to be fair. But medicines aren't really effective for personality disorders. They're really, really not. And often it's just sort of, well, we'll sedate you enough that you're not really bothered by this anymore. But yeah, they're not great. You're supposed to use them for comorbidities. But some people with personality disorders get very heavily medicated, especially people who don't actually have personality disorders, because there were a woman with autism who got misdiagnosed because she lashes out because nobody really understands what she's feeling, or the fact that her brain can't really process certain stimuli. First line for EUPD, dialectic behavioral therapy, like Lizzie said. Dialectics is based on the premise that, well, it's a philosophical thing of two people with opposing views working together to try to come to a shared proof. The way I see it, and the way I've explained it to patients, is that it's the idea that two things can coexist at the same time. In EUPD, two sort of contrary things even. EUPD, the patient, let's say the patient is trying their hardest to get better, but it's not enough, which was almost contrarian. But the way I've explained it is, you have been trying to escape from a prison cell using a toothpick. This therapy is going to try and equip you with a chainsaw. That sort of thing. So it's acceptance that what you have at the moment isn't ideal, but 4 modules to sort of work through it. So distress tolerance and emotional regulation, mindfulness, and interpersonal effectiveness. And then the mainstay for everything else is treat comorbidities. That's personality disorders. So highlight EUPD, and then the others are just unfortunately know the stereotypes for SBAs. If they ever brought it in an OSCE station, it's going to be EUPD. There is no way they're going to give you schizoid personality disorder as an OSCE station. If they did, I would probably burn down the Rockefeller building in protest for you guys. Right, let's talk about eating disorders. So, eating disorders, again, I'm not going to bother asking you guys what the definition is. It's just abnormal eating habits that negatively affect a person's physical and mental health. And the physical bit is important, because the important thing with eating disorders is when you remove suicide, they have the highest mortality of any psychiatric disorder because of the physical complications. A lot of focus is on the 2 dominant ones, which are anorexia nervosa and bulimia nervosa. But remember that they are a very, very big family with a lot of other disorders in there as well. But these are the 2 that you are going to see most often. What's an important thing with and a useful thing to know, especially if you're doing like an F2 job in gastro or something, with eating disorders and the Mental Health Act. I know we haven't talked about the Mental Health Act in a while, but we can do that at a later point. But this is quite important. Yeah, perfect. So Olivia said you can refeed patients under the Mental Health Act, and that's really, really important to know, because remember, the Mental Health Act doesn't allow you to carry out physical, to do something physical, unless it's secondary to the consequences of a person's psychiatric illness. Even ECT, electroconvulsive therapy, is very tightly regulated. If you want to do ECT against somebody's will and they are sectioned, you still need to get a second independent doctor. Pardon me. You need to get a second independent doctor to assess the patient. But in eating disorders, if the patient does not have the capacity and is in, their life is in danger, like Olivia said, you can refeed under the Mental Health Act, which is the only example I can think of where a patient under the Mental Health Act can be subjected to physical treatment without the need for a second doctor to reassess. Right. Let's talk about anorexia. So what's the sort of headline with anorexia? If you had to, what characterizes anorexia? Yeah, so it's this fear of putting on weight, which leads to almost a restrictive pattern. It's characterized by this deliberate weight loss that the patients. It's not, for example, a patient loses a lot of weight because they had diabetes and then goes, oh, I quite like this, I'm going to try and maintain it. It is the patient has deliberately induced the weight loss and it's gotten to a point where it is pathological and dangerous. Obviously, it's more common in girls and young women, but it does happen in men, and sometimes that can get forgotten. It's got a fairly specific set of diagnostic criteria. So I need to change that. The BMI should be less than 17.5, not 7.5, because otherwise they would be dead. Its body weight is maintained at less than 15%, and they self-induce the weight loss, which is what we said. And there's multiple ways of doing it: appetite suppressants, excessive exercise, purging. So purging can happen in anorexia as well. We'll talk about the difference slightly later between anorexia and bulimia. There's the body weight distortion, which Olivia's kind of touched on, which is a patient with anorexia, despite you look at them and you can see that they are incredibly malnourished, almost lethally, they will see themselves as fat, overweight. It is practically delusional, actually. It's basically a delusional belief. And the really important thing, this is what makes eating disorder psychiatry probably one of the more medical parts of psychiatry, is that there's a lot of endo in it. In fact, they kind of need to have a gonadal axis disturbance. So women, that's their periods stopping or never starting if they develop anorexia quite young. Men, it's loss of libido and potency. There's the thing on PassMed, which is everything is low except the C's and the G's, which we'll touch on later. I remember that puberty may not even happen if someone develops anorexia earlier enough. Those are the criteria for typical anorexia. If one or more is missing, but their clinical picture is basically anorexia, that's atypical anorexia. This is in comparison to bulimia. So the big thing that differs anorexia from bulimia is the preoccupation with food. You can't stop thinking about the food. Whereas anorexia, it's fear of getting fat. In bulimia, the preoccupation is food. I can't stop thinking about food, and I absolutely hate it. And then these extreme, you have the binges, which is you eat an incredible amount of food in a very small period of time. And we're talking very small periods of time, like 10 minutes, and taking in a large amount of food, which are then followed by purges. It can come a bit later than anorexia. And often one can follow the other. A patient with bulimia can slip into anorexia, or a patient with anorexia, as they're recovering, may then develop into bulimia. So the criteria are that there's a preoccupation with food, and that's basically the most important thing that splits it from anorexia. Some people talk about weight and so on, but it doesn't have to be like that. It's the preoccupation with food that really splits it. And they are also afraid of being fat. And like we said, you need to exclude something like, I don't know, Zollinger-Ellison syndrome, however rare that would be, or chronic gastritis before you can diagnose it. And often, if they've got a physical thing, they're not going to have the psychological profile of somebody with bulimia. But also depression, because remember, somebody with depression may overeat, but they're not overeating because they're preoccupied with food. They're overeating because it's a coping mechanism. Personality disorders, or genetic syndromes that lead to overeating. Like, someone think of a genetic syndrome that leads to overeating. That's a classic one, actually. It's a result of imprinting. God, that was ages ago. Second year. Can't remember what the professor's name was for genetics. Yeah, Prader-Willi, perfect. Prader-Willi is really intense. There's my friend's, a friend of mine's mum, her husband is a carer for a patient with Prader-Willi, and everything is locked because they have very intense pica. They will eat anything and everything. But it's quite rare, so you won't often see them. Really important point, not so much for exams, but for future practice. Unless you are taking a history from a patient, do not, for the love of all that is holy to you, or unholy, or whatever, do not mention purging methods. This is an important thing because generally talking about mental health is quite good. There's this fear, for example, that if you ask somebody if they're feeling suicidal or give them the idea, which has been found not to be true through multiple studies, talking about purging methods is one of, well, possibly the only thing that goes the other way, which is if you tell somebody about purging methods, you give them, and they have an eating disorder or are vulnerable to it, they are more likely to do that. So unless you are taking a history and you're asking a person, do you do this, do you do that, do you do this? Like, for example, if you're teaching, I've done quite a bit of mental health workshops and stuff for children in secondary school and so on, and it was a sort of thing where under no circumstances could you mention how people purge. And I'd been asked multiple times by some students, oh, how do people purge? And going, no, I'm not telling you this, because that's one of the few things that will actually give them ideas. No worries. It's probably one of the most important things I can say in this one. Unless you're taking history, do not start mentioning that stuff to like a young teenager or whatever. And the other really important thing, which is an increasing phenomenon, have people heard of diabolia? This is probably one of the most dangerous manifestations of bulimia. Yeah, perfect. Perfect. So it's patients, insulin-dependent patients, often because they're quite young, they're patients with type 1 diabetes, who will withhold their insulin in order to put their body into a ketotic state, because you lose weight when you're doing that, you resort to burning adipose tissue. And obviously that's incredibly dangerous. You're going to give yourself DKA. So it's really, really important to assess, especially patients with type 1 diabetes who are in the risk group for bulimia, so adolescent, female, to watch out for if they've got something like poor glycemic control or so on, to think about, wait, hang on, could this be something psychological? Because obviously that is fatal. Quickly to talk about the sort of physical stuff. So because these patients can sometimes present with physical symptoms. So what sort of physical symptoms might a patient present with in terms of anorexia? So these are symptoms. We'll talk about signs in a second. Fatigue is an incredibly common one. Lightheadedness, good. This is one that we mentioned earlier, certain girls, which can sometimes be a presenting complaint. Concerned mum brings her daughter in. Amenorrhea, perfect, yeah. So my daughter's periods have stopped, or she's 14 and she hasn't started her periods, and I started at the age of 10, and her sister started when she was 10, so I don't think it's a genetic thing. So that's quite a common one. What about signs? What might you see in a patient that makes you a bit worried? Lanugo hair, perfect. Yeah, so I was going to ask what Lanugo hair is like. Yeah, it's that baby-like hair in sort of the body's desperate attempt to try and keep itself warm, because they'll often come in with cold intolerance. Yep, so Lanugo is the typical SBA one. What other things? Yeah, so enlarged parotids is more common in bulimia. Why? You can get it in anorexia if they do, well, the thing that causes the enlarged parotid glands. Yeah, perfect. You're inducing vomiting and you're creating quite an acidic environment in your mouth, which is compensated for by the secretion of bicarbonate in saliva. So you get parotid gland hyperplasia. You get gland hyperplasia, so they get bigger parotid glands. That's a really good one. So if a patient with anorexia is purging through vomiting, they'll get that, but it's more common. It's more common in bulimia. What else? Yeah, so the obvious one, which is a very, very thin appearance, which was almost immediately apparent in a patient with anorexia. Good, proximal muscle weakness, because what's one of the important tests when you're sort of going for severity of an eating disorder? Squat test, perfect. And what is the squat test? No, it is called a squat test, you're absolutely right. What does it involve? Yeah, exactly. It's pretty much the same thing that you might do in a thyroid exam. You don't even necessarily need them to squat. I know, yeah. So low squat. Sometimes they might not even be able to stand themselves out of a chair. One of the reasons why this might be falsely reassuring, keep this in mind, is since a lot of patients with anorexia excessively exercise, they might still be able to do that because they are, in terms of musculature and so on, not in the worst shape. So often, if they can't do that, it's really, really severe. But if they can do it, it can be falsely reassuring. They can still be quite unwell. Okay. What about OBS for a patient with anorexia? If you did their OBS, what might you notice? Perfect, Brady. Hypertensive, good. Especially low temperature, good. And you're all sort of going for things which are really important to assess for, because these are some of the urgent referral stuff. Good. And then that sort of examination stuff. What about bloods? What sort of stuff comes out on bloods? They're often anemic, which isn't surprising. Yeah, exactly. Most things are low. Yeah. So the hypochloramic alkalosis. What is the most common cause of a hypochloramic alkalosis? If you see that in any patient, what are you thinking? Yeah, perfect. Vomiting, especially protracted vomiting. You're chucking out loads of hydrogen chloride, stomach acid, so your chloride drops. And in order to save protons, you exchange protons for potassium ions. So potassium ions go into the cells, into the parietal cells, whilst protons go out to maintain the acidity of the stomach, so you become hypokalemic as well. Perfect, okay. And complications, so this is the really important bit if you don't go into psychiatry. What are some of the complications? Of an eating disorder? Perfect, arrhythmias, that's what kills. Your EDSHO, 23-year-old woman comes in incredibly thin and confused. What are you worried about? Can't really walk properly. And when you do cranial nerves, a sort of H test is a bit weird. Her eyes seem locked in position. Perfect. Wernicke syndrome, which can lead to Korsakoff. Remember, they're not eating, they're going to get a thiamine deficiency if it gets bad enough. Don't forget about Wernicke syndrome, because obviously once it gets to Korsakoff, that's irreversible. So a real quick run through the rest of them. So we talked about the lanugo hair, acrocyanosis, just sort of dusky peripheries because of hypoxia there due to poor cardiac output. You've talked about hypothermia, talked about the squat test, and we've talked how most things are basically low. You can get deranged, for example, your potassium going up if their kidneys shoot off because there's not enough renal perfusion, but mostly stuff's low, and you need to watch out for the QT interval, which is the big thing in cardiology and psychiatry. And we've talked about Wernicke-Korsakoff and arrhythmias. Remember, their menopause can go early, which leads to osteoporosis. They can get seizures because of the electrolyte disturbances, and refueling syndrome we'll touch in a sec. That'll be the last thing we do. And then bulimia, we've talked about all the anorexia stuff plus just GI stuff. So GORD symptoms, abdo pain, the other signs being the dental erosions and the knuckle calluses, and salivary gland enlargement if they vomit. We talked about the hypokalemic metabolic acidosis and the prolonged QT, and the complications are much the same, except the complications of prolonged vomiting. Mallory Weiss, if it's really bad, then they can get Boerhaave's, which has a mortality of 30%. They can also get Barrett's esophagus, so you can end up with esophageal cancer from bulimia, and then arrhythmias and osteoporosis. Real quick management of these conditions. So what's the mainstay for management of eating disorders? Yeah, so they need to get their weight back to do all the physical side, but to actually deal with the eating disorder, what you're going to give perfect therapy. Medicine should never be offered as a standalone. Basically, by and large, if they're an adult, CBT, specialized in eating therapy. If they're a kid, and this is an SBA one, what is the first line for a young person with, like an adolescent with an eating disorder like anorexia? Family therapy, exactly, because family dynamics are really important in eating disorders. There's a higher risk if you're going to live in a high-pressure family, a parent who's particularly health-focused, body image-focused. So it's really important to get family involved so they know this is not a good behavior. You know, stop saying this in front of your kid. It's making it worse when you comment on their size, or when you comment on portion sizes. So family therapy is really important in children. Very important, and you've already touched on most of these. These are the criteria for an urgent referral to peds at the bottom. If they've lost more than a kilo a week or more for 2 weeks, if they're bratty when you see them, if they've had recurrent syncope, marked orthostatic hypertension, so a 20 millimeter mercury drop in systolic blood pressure, prolonged QT, if they've got an electrolyte abnormality, if they're refusing to feed and they're severely dehydrated, hypothermia, any of the hypos on the blood tests, if they're limiting to 600 calories a day at most, if they fail the squat test, and in most places BMI under 15. BMI under 15 is like the upper limit for admission, because there's a lot of pressure on eating disorder beds. So the upper limit for admissions, often you need to have a BMI of at most 15, which is kind of horrific when you think about it, because then there are lots of other patients who don't get admitted who really do need admission. But that's because there are just so few beds, and you hear these horrific stories about patients having to go miles away to get an eating disorder bed. So those are your red flag ones. The one that's most likely to come up in SBA is the patient fails a squat test. But these are good to know. If a patient has any one of these warrants an urgent referral to your nearest pediatric ward. Finally, refeeding syndrome. Why does refeeding syndrome happen? I'm big believer in the physiology. Anyone who you suspect has an eating disorder in GP, you're going to refer them. Obviously, you're going to discuss it with the patient. If they have capacity, then no. If they have capacity, then no. If they don't, then you'd encourage it. But the only time where you're sort of going against their wishes is if they are really in danger. And in that case, you're going to send them to peds, and they'll get assessed by the CAMS liaison team whilst they're there. But anyone who you suspect has an eating disorder, you ideally want to be referring to eating disorder services, because they're lethal if untreated. Okay. And then refeeding syndrome, what's the pathophysiology behind it? Because there's only one thing you need to know for SBAs, which is, oh, you're feeding someone, their phosphate is low, refeeding syndrome. But in real life, it's quite useful to know what's actually happening and why it's so dangerous. Perfect. Yeah. So you've this person who's been fasting for ages, their insulin levels have dropped off, and suddenly you're feeding them and their insulin spikes up, and to phosphorylate glycogen, you need phosphate, so their phosphate drops. And you need calcium and potassium, which are already quite low, so those shift into the cells, and they're already low enough, so they'll get the hypokalemia, they'll get arrhythmia or heart failure, because the fluid balance is just wrecked, or they'll get convulsions. So phosphate's the most important. If it's low, you restrict the calories, you replace minerals, so like phosphate or calcium, and treat any complications like arrhythmias. But that's the really, really important bit. It's the phosphate goes low. And why does the phosphate go low? Because you need to phosphorylate compounds. Back to a horrific Krebs cycle in first year. But yeah, so that's it. Sorry, overran slightly. I'll just stop presenting there. If anyone has any questions, let me know. Also, the office still stands if anyone needs to thingamabob, talk about this, wants to talk about this afterwards, particularly hit close to home, then yeah, message me on Facebook. I'll stick around. If you could just do the feedback, please, that would be much appreciated. Let me just copy the link. No worries, guys. Also, do say in the feedback form what other stuff in Psych you want. So I'm more than happy to go through through stuff like psych drugs. What was the other thing that I thought might be quite useful? Going through the psych pharmacology, and there was something else, but basically put in the feedback if there's any particular bits of psych that you want to go through. I imagine pharm's probably the most important one. Overdose management as well, I'm happy to do, and any substance misuse stuff. There's not much of it. After specialist services, there's specific admission criteria for adults. Yeah, that's where the Marzipan stuff goes. So that's a good question. So the Marzipan guidelines are the Royal College of Psychiatrists guidelines for, well, everything to do with eating disorders. So specialist services usually, specialist services might decide if somebody needs to be admitted, but sometimes someone might go straight to admission, be admitted straight from GP if, for example, they fulfilled some of those guidelines, some of those criteria that we talked about earlier, like they can't stand up from sitting. We'll send them to peds because likely they will need some physical stuff like fluids and so on, but then after that they're probably going straight to an eating disorder, inpatient eating disorder unit. But yeah, the community eating disorders teams are governed by the Marzipan criteria, but they're also somewhat relevant to, well, every service. Sorry, that was a very vague answer. No worries. Please stay safe, everyone. You don't have the luxury of not going in and stuff like the final years do, so please look after yourselves. Stay safe.